Performing a complete ileocolic exploration is one of the basic pillars of diagnosis and monitoring of inflammatory bowel disease. The insertion tube for standard colonoscope has a diameter of between 1.3 and 1.5 centimeters, with a working channel of 3.8 millimeters and length of 160 or 170 centimeters. The pediatric colonoscope enables passage through a difficult sigma or the passage through a stenosis, and the therapeutic colonoscope with a larger working channel, stent placement. There are also double-channel colonoscopes for simultaneous insertion of two working channels, and colonoscopes of varying stiffness to flexibly negotiate angulations or avoid recurrence of loops when stiffness is increased. The control head can be handled using the two-hand technique in which the left thumb handles the vertical control wheel and the right hand the lateral control wheel, while the tube is inserted by an assistant or with a single hand, with the left thumb controlling both wheels and the endoscopist himself inserting the tube, which enables a more smooth and effective insertion. The patient is positioned in left lateral decubitus with the thighs flexed and the right knee in front of the left. Insertion begins with a rectal exam that evaluates a potential anal pathology and allows for insertion in the rectal ampulla, in which the rectal lumen is located with the least insufflation possible and a slight pulling back. A rectal retroversion maneuver with maximum upward angulation may be necessary while introducing the endoscope to obtain a 360-degree view. The sigmoid colon measures 40 to 70 centimeters during insertion. Once the endoscope is straightened, it shortens 30 centimeters, which is why it is important to assess the lesions during entry, which is done by a slight rotating with the slightly bent tip. Advancement through the sigma reproduces an N loop, and it is important to remove the endoscope by rotating clockwise and to use suction to advance, sometimes with assistance by manual compression of the hypogastrium. An excessive tube length can produce an alpha loop. In these cases, it is preferred to continue up to 90 centimeters and remove the tube, straightening it up to approximately 50 centimeters away from the splenic flexure. Upon reaching the transverse colon, avoid tip overangulation and use suction, as it is a simple exploration, except in cases of abdominal laxity in which epigastric compression enables passage. In the hepatic flexure, after straightening the position, initially a turn is made to the right and then to the left while suctioning to allow progression. Acknowledgement of the appendicular orifice and converging longitudinal tenei confirms the arrival at the fecal fundus, where the ileocecal valve is observed when pulling back, which is how the ileum is accessed, an important exploration in managing the disease. With the patient in supine position, the valve is visualized at 9 o'clock and between 6 and 7 o'clock with the patient in left lateral decubitus. In both positions, it is recommended that the lower lip of the valve is separated and a turn is made to the left. If the valve is situated at 1 o'clock, one must combine bending upwards and turning to the right. In case of a valve with very thin lips, retroversion of the endoscope may help to identify them. In the removal process performed with controlled insufflation and the straightened endoscope, a careful inspection must be done, as well as biopsies or other unscheduled treatment procedures.